The following is a recording of the ACS webinar from March 17, 2021. Dr. LeMay is an interventional cardiologist here at the Heart Institute and director of our regional STEMI program. He presents here about the management of NSTEMI patients.
Objectives here are listed. We want to standardize therapy across our LHIN, and I'd like to introduce the concept of primary ACS in the form of a type 1 MI as defined by the universal definition of MI versus secondary ACS. Now, nobody in the literature talks about this, and I have to say that I borrowed this from one of my colleagues, Dr. Froschel, who is a very big proponent of using this classification rather than the one that others have been using. We want to talk about new LHIN guideline poster that we've developed. We want to review the poster in detail and see how it can apply to our patients. And we want, in doing so, identify patients who need urgent coronary angiography. So let me start off with a few cases. I'll run through them fairly quickly, just to give you a feel. And I'm sure that for those of you that work with patients in the emergency department or admit patients to the wards, that you're a little bit familiar with these cases. Here's a 65-year-old male presenting to the emergency department with progressive chest pain, initially with exertion, now with one 20-minute episode at rest. And he has hypertension and he is on beta blockers. In the emerge, his blood pressure was measured at 150 millimeters of mercury, and his first set of biomarkers was positive. The EKG is the following. And you can appreciate, looking at the precordial leads, that there's some changes that don't belong there. He's got some ST depression in several of the leads, and that highlights an EKG finding that is quite abnormal that would put him in a higher risk category. The management of this case, the question that I would ask you is to think about what is the diagnosis, which medications would you be prescribing in terms of antiplatelets or anticoagulants, and how would you investigate that patient? In contrast, we have this 68-year-old female who presents in the emergency department with shoulder pain radiating to her back, and while waiting for an EKG, she suddenly experiences a cardiac arrest. She's promptly resuscitated from Afib with 2 shocks, and an EKG is shown in the next slide. So this EKG is also a very abnormal EKG. Some people would call that a Wellens type A EKG. We see some ST segment, really borderline ST segment elevation, but T waves that are biphasic in V2 and in V3, and very deep T waves in V4 and V5. So you'll hear our resident talk about a Wellens type of EKG, and they talk about this because this is an EKG pattern that is associated with a vessel that is open, but a very tight lesion, specifically with concerns about the LAD territory. So again, we ask ourselves, what's different between the first patient and this patient? What's your diagnosis? What medications you'd be using? And how would you investigate that patient? The next patient is a patient, 72-year-old lady that presents with dyspnea to the emergency department, and she has a history of cigarette smoking. She has also got a history of atrial fibrillation on rivaroxaban. She's treated with puffers for COPD. Her blood pressure is 150 and her heart rate's 130, and her chest X-ray shows pneumonia in the right middle lobe. The serial biomarkers are elevated, and EKG is the following. So we see on this EKG that she does have atrial fibrillation. She doesn't have a pattern of either ST or elevation or depression. So we have a lady here that presents with pneumonia, some troponins, shortness of breath, and an EKG with atrial fibrillation. So again, what is your diagnosis? What medications would you prescribe to this patient? How would you investigate this patient in light of in view of the elevated troponins? So in putting this talk together, I went back and looked at the guidelines, and the most recent guidelines have been generated by the Europeans and are published in the European Heart Journal, while the American guidelines were published back in 2014. So we have two sets of guidelines to help us out. The most current one being the European guidelines. This is a older slide that we've been using for years. And what it does, it divides the patients with ACS into non-STEMI on the left of the screen and STEMI on the right side of the screen. Basically, ST elevation, if it is just very transient ST elevation and it comes back into the field of non-STEMI. And we define a myocardial infarction in terms of elevated biomarkers. So if the patient has no elevation of biomarkers, may have some EKG changes, but no elevation of any biomarkers, we would consider the diagnosis of unstable angina. Now, I think it's important that we get into a differentiation of myocardial injury from myocardial infarction. So myocardial injury is an elevation of troponins. And we see this all the time in the emergency department with various diagnoses coming in, whether it be somebody with myocarditis or somebody with rapid atrial fibrillation or somebody with patients with renal insufficiency. So there's evidence of myocardial injury, elevation of the troponins. But what makes it a diagnosis of myocardial infarction? In order to have an acute MI, you need myocardial injury. In other words, you got some biomarkers that are elevated, but it has to be in the context of acute myocardial ischemia. So it requires one of the following: symptoms of ischemia, EKG changes, and if you watch the patient long enough, development of Q waves on ECG, or you can do it by imaging. You can diagnose a new regional wall motion abnormality on a TTE, or if you do a coronary angiogram, you find thrombus in the coronary artery. So you have to distinguish myocardial injury from myocardial infarction, and that's important. Why is it important? Because it helps us understand and manage these patients that come in with elevated troponins. So there is a definition that has grown over the years called the universal definition and myocardial infarction, and you see the reference below. There are basically 5 types, but I'm going to go over only 2 types because the other types don't apply to the discussion for today. A type 1 MI is characterized by atherosclerosis, plaque rupture, ulceration, and fissure or erosion with resulting thrombus in one or more coronary arteries, leading to decreased myocardial flow and or distal embolization and subsequently myocardial necrosis. So basically, it's a plaque rupture. And we have an example here on a coronary angiogram as shown by the arrow, an area where it's hazy, where there's plaque rupture, and this is responsible for the acute coronary syndrome. In this case here, the artery, which is the LAD, is still perfused because there's contrast going down the vessel. But if that artery completely shuts down, you would have completely occlusion, would likely provoke an acute myocardial infarction in the form of a STEMI. So this is what we see quite commonly with non-STEMIs. And in the context of a plaque rupture, we see the pathological specimen here that shows where the plaque rupture took place, where the arrow is pointing to. And then as a result of that, you get platelets that aggregate. The aggregation leads to triggering the coagulation cascade. And next thing you know, you have a clot that fills the coronary artery. And you have, if it's temporary, then you have resolution of the syndrome in terms of chest pain and ST segment elevation. It resolves, but if it doesn't resolve and it stays plugged, then you have a STEMI. So when we take patients to the cath lab, in the past, and we still do, we'll aspirate from time to time thrombus within the coronary artery. So that last case that I showed you with the angiogram, if we had put a aspiration catheter and just with suction taken out the clot, we would simply flush it into a little basket like this. And we don't do this routinely anymore because it's been found that it doesn't help, but it certainly explains a little bit why earlier on, many years ago, we used to give thermolytic therapy to patients with STEMIs. Here's an example of a patient where we use basically fiber optic technology. It's called Optical Coherence Tomography. And in this case, we pass this little light inside the coronary artery over a wire. And we see here red clot and we've learned how to characterize these. And then the other cartoon here, we see the ruptured plaque. And this is typical of a type 1 acute myocardial infarction where there's ruptured plaque. And this is what, the universal definition typically describes as a type 1. So what about this type 2? The type 2 MI is also myocardial necrosis, in which a condition other than a coronary plaque instability causes an imbalance between myocardial oxygen supply and demand. So the mechanisms, for example, somebody is either hypotensive or hypertensive. Somebody comes in with atrial fibrillation with a very fast heartbeat, somebody with severe bradycardia, profound anemia, hypoxemia, or coronary spasm. And they include also SCAD in this type 2 MI, as well as coronary embolism. For example, somebody's got atrial fibrillation and embolizes down the coronary artery. And here's an example of taking a patient with SCAD, the spontaneous coronary dissection, to the cath lab. And you can just appreciate that there is a dissection that has taken place and there's an intramural hematoma that is formed, and we can see it on the OCT. This is the kind of patient that we more typically watch afterwards rather than stent. But this is how this OCT catheter can help us with the diagnosis when we feel that it's still ambiguous. So coming back to one of the objectives was to how do we define more clearly the types of MI that would help us take care of our patients in the terms of a primary MI versus secondary MI. In a primary MI, it is the coronary artery circulation where an accident has taken place, where it is responsible for the event. So we talk about a type 1 MI, which is a ruptured plaque, but we would move SCAD from a type 2 MI into this primary MI category. In the secondary MI, ACS, is mostly type 2. These are the ones we talked about, arrhythmias such as rapid atrial fib and anemia. And the reason for defining it as primary MI versus secondary MI is because we believe that the treatments and the investigations are going to be somewhat different. So we talk about like what can cause myocyte injury, rise in troponin, and we often get patients that are referred to be evaluated because they've had a trope rise. And in this situation here, we have a long list of other things besides type 1 MIs that can lead to elevation in troponins that are not necessarily myocardial infarction, but are myocardial injury. For example, myocarditis, you may have an elevation of troponin, and it's not a myocardial infarction. So it is important to recognize that difference because you want to treat the underlying cause. If you have, for example, somebody that presents with pneumonia, like our case 3, that patient, although that patient has an elevation of her troponins, we would be more concerned and more focused on treating the pneumonia and then later addressing the rise in troponins. Now let's go back and understand where we've come from. And I got this when I was, I started my training program, and I was told that, many years before me, there had been a Peter Gaze from, I think he was from South Carolina, that had compiled 10 years of data on patients presenting with ACS. And what this slide highlights, and it's probably the only natural history publication on acute coronary syndrome that you will find. And he published this back in Circulation. And what you see at the bottom in yellow there on the left, at 120 months, basically, at 10 years follow-up, the survival was less than 20%. So this is a disease that left unchecked in an acute coronary syndrome without any therapy is associated with a really bad outcome. It is as bad as many of the cancers that we know. And then a Canadian, Coherence, who did an acute coronary syndrome study looking at aspirin, found that aspirin was also important in prolonging survival. You can see on the scale that at 18 months, when he looked at mortality, there was almost a 4-fold difference in mortality when the patients were treated with aspirin when they presented with their acute coronary syndrome. So aspirin has been there as the first line drug. It's been the cornerstone, basically, of the treatment of non-STEMI from the very beginning. And then came Cure was driven by Salim Youssef out of Hamilton, which looked at dual antiplatelet therapy with clopidogrel. And in that study, they were able to show that dual antiplatelet therapy consisting of aspirin plus clopidogrel was superior to being treated with aspirin alone. And the primary outcome was death, MI, or stroke. And the dual antiplatelet therapy reduced this in a significant way, in such a way that it made its way into the guidelines. And we recommended that dual antiplatelet therapy be started in emergency departments. And for those of you that are old enough that have grown through this change in therapy, you'll know that we basically instructed everybody in the emergency department that when you make a diagnosis of an acute coronary syndrome, you start with clopidogrel. But one thing I want to show you about this study is the following. And this is the reason why we went out and said, you got to start this in the emergency department. When you hit the hospital, you got to start early. Because in that study, the curves separated very early. The benefits were seen within hours and continued to increase over the 12-month span. So that was part of what we did, is we went into our community, into our LHIN, and basically instructed all of you that are working in the peripheral hospitals, in our own emergency departments, that we should start with dual antiplatelet therapy there. And the reason I bring up this point is most recently, remember the guidelines that I showed, the European guidelines have kind of suggested that maybe not, maybe we should not be starting the antiplatelet therapy with the dual antiplatelet therapy with the other drugs that we have as early as the emergency department, but we should be waiting for the cath lab. The reality check here is that in Europe, they have a great number of cath labs, and the practice is to take their patients within a few hours to the cath lab. And this is something that in our context, in the Canadian context, we certainly can't allow ourselves to do. Now, going back to this study that came back, it was published in 2007, the Triton study. It looked at another P2Y12 blocker, prasugrel, and it showed that it was better than clopidogrel. Prasugrel did not really make a strong, it didn't make it very strongly in our Canadian market, and it's no longer used. Instead, we learned from Plato that ticagrelor also was a very good drug and better than clopidogrel. And in this study, not only did it reduce death, MI, or stroke, but it also reduced death on its own, and it reduced stent thrombosis. And we kind of started blending ticagrelor into our STEMI program and also in our non-STEMI program. We started using it in all our ACSs. So in the management of these patients, where we are treating them with these antiplatelet therapy, and some are more powerful now, we have a risk of bleeding. And so in assessing our patients, it's important that we balance the risk of ischemia against the risk of bleeding. For example, somebody who is elderly, somebody who has already had bleeding issues, somebody who's had a previous intracranial bleed, these patients may pose a greater challenge in terms of using the kind of pharmaceutical strategies that we are proposing at times. So it's important that when we treat our patients that we try to standardize things, and we learn how efficient that was with our STEMI program. But there are some really, there are some variations in ACS that make one question standardization, and standardization is important, and that's what we're trying to do today in some ways, is standardize our LHIN with algorithms. But we have to remember that as we are standardizing, we have to be able to, as clinicians, be able to change gears. And so if you have somebody that's a little different, like case 3 that comes in, who's on already on oral anticoagulants, some of the standardization that we would do we may have to adapt and make some recommendations for those patients as well. So we had in the past developed posters for ACS, and on the left on using antiplatelet therapy when Plato came out, and on the right a way of assessing patients in terms of deciding how we go to the cath lab. And we decided to take basically these posters, and we worked on this together and blend them together, formalize a poster that would be more appealing for all of our LHIN. So this is the poster that we are circulating now. This is the contemporary poster that we've all worked on together. And what I want to do now is sort of break it into its parts. So the first part is the presentation of the patients, which deals with the symptoms of acute coronary syndrome. Talk about chest pain, dyspnea, nausea, diaphoresis, weakness, hypotension, presenting within 24 hours, and looking at the symptoms and fitting them together with the history, with the EKG and the biomarkers, and coming up with, an approach in terms of how we're going to manage these patients. And you see that I've kind of left out the old TIMI scoring system, the GRAY scoring system. We want to keep it simple. You take a history, and is that the history that sounds like an acute coronary syndrome? You look at the EKG, you're looking for dynamic EKG changes, whether it be ST changes or T-wave changes, and you're looking for the biomarkers, and we're strongly advocating serial biomarkers because serial biomarkers are helpful in making the diagnosis of acute coronary syndrome. And looking in the past at patients with ST segment displacement, and the curves show their ST depression and then ST segment elevation, and it compares it to T-wave inversion, you will note that survival, mortality is impacted by ST segment displacement. In other words, if you got ST segment displacement, whether it be ST elevation, transient ST elevation, or ST depression on your 12-lead ECG, that's worse than having T-wave changes. We also know that if you measure troponins, and that's one of the reasons why it's important to measure serial troponins, that the higher your troponins, the worse is your prognosis. So we triage the patients a little bit on the basis of the elevation of their troponins. So if they have very markedly elevated troponins, the prognosis is going to be much worse than if you have just a nudge above normal with troponins. And so when we look at treating our patients, one of the questions we have to ask ourselves, is the patient actively bleeding? And if the patient has active bleeding, and let's say melena in the last 2-3 days, then what we would recommend is that you consult with your hospital cardiologist, or you give a call to the Heart Institute, and we'll help you out with those patients, because those are special patients that are definitely at increased risk. If the answer is no, and you don't have active bleeding, then you have to consider a strategy of antiplatelet therapy and anticoagulation. And the question is the patient taking oral anticoagulants? And most of the patients coming with an ACS are not on oral anticoagulants. So if you look at the left panels, the answer being no, then you would we would make the following recommendations regarding antiplatelet therapy. We would want you to load your patient with aspirin, and then we would prefer that you use ticagrelor over clopidogrel. The dosages are there for the loading and the maintenance. And in the middle, there's the anticoagulation therapy, and you can choose one of the three. One of them that's listed there is fondaparinux. I think that many in our community hospitals are not completely familiar with fondaparinux. We have not been using it a lot. Most of you are familiar with enoxaparin, and the dose is given there. And I would point out that with both fondaparinux and enoxaparin, it's important to know the creatinine clearance, because if the creatinine clearance is below 30 mils per minute, you probably should not be using these medications. In very high risk patients, and we'll talk about how do we define these very high risk patients, we would recommend that you use unfractionated heparin. And the reason for using unfractionated heparin is because in these very high risk patients, we would recommend that you transfer them to the Ottawa Heart Institute as soon as possible to undergo early coronary angiography, and to avoid the kind of mixtures where we get somebody on enox and then not long afterwards on unfractionated heparin in the cath lab. It's easier because most of our interventionists are more comfortable with using unfractionated heparin in the cath lab rather than enoxaparin. Now, some centers in the world, like for example in Paris, Montelesco will use enoxaparin for all his patients, and he uses enoxaparins in the cath lab as well. But it has been our choice to use unfractionated heparin because we feel we can titrate it better in the cath lab, and we can measure the ACT, which helps us determine how much anticoagulation to use. On the right side, we see that these are patients that are on oral anticoagulants as they come in through the door. We load them up with aspirin, as you would normally do, but instead of using ticagrelor in these patients, we would prefer that you load them with clopidogrel. And then the question becomes, should you be putting them on any form of heparin? And I think that you have to use some caution. If they're already anticoagulated and you give them enoxaparin, now you got a medication that might be sticking with them for quite some time, and they may be at risk of bleeding, and especially become more complicated if they need to be transferred for urgent coronary angiography if they become more unstable. So I think these are special patients. You have to evaluate these patients more on a case by case basis. There are some patients that are obviously more ill, that they are more unstable, and they will need urgent cardiac catheterization. And we know from our STEMI protocol that when we looked at patients that came in on anticoagulants, that there was definitely more bleeding in that situation. But sometimes the dice are cast, and we have to proceed with coronary angiography. Now, looking back at this slide here, which was a meta-analysis of the Essence trial and the TIM-11B trial, and it was used basically to show that enox was better than unfractionated heparin. It's a really old slide. It's more than 20 years old. But what it did is that we went out in the periphery. We told the community hospitals, start using enox. And that's a little bit the reason why many of our community hospitals now use enox, is because of our teaching of many years ago to switch over to enoxaparin. But what about this Michelangelo study, fondaparinux? The fondaparinux is a synthetic anti-10A. It's a pentasaccharide. And what it does, it blocks 10A. And in a study called Michelangelo, they showed that fondaparinux actually improved survival compared to enoxaparin. And also, it was associated with a lot less bleeding. So if you were practicing in the McMaster area, and McMaster ran this study, most of the community hospitals there will use fondaparinux as opposed to enoxaparin. In our situation, we've seen a growth of fondaparinux, especially in the patients where we feel that they don't need to go to the cath lab right away. Patients that we want to further investigate non-invasively. Here at the Heart Institute, we've seen a number of cases which are now treated with fonda rather than an enox. In this complicated slide, the only purpose of this slide is to let you know that there is now a number of trials that have been looking at patients that come in with atrial fibrillation that go on to PCI. And now you need for atrial fib, you need an anticoagulant. And for the PCI, you need antiplatelet therapy. So you need double antithrombotic therapy versus triple antithrombotic therapy. And these are the studies that have tried to answer that question. And what we're seeing in what's coming out of these studies, they're all kind of siding on the same side and suggesting that double antithrombotic therapy is safer. In other words, it is safer than using triple therapy. And you do that by dropping the aspirin. So an example in the Pioneer trial, it would have been rivaroxaban plus clopidogrel, where they dropped the aspirin. A triple therapy, they would keep the aspirin. So we're seeing a lot less bleeding by using dual antithrombotic therapy. Now, some of the interventionists are a bit concerned that we're dropping the aspirin maybe too early, and that we will see some ischemic events, some stent thrombosis. And so there's still some variation on how we want to handle the problem, and you'll see different recommendations depending on who deals with the particular case. And some people will drop the aspirin immediately, and some people will wait a month before they drop the aspirin. And here are the Canadian guidelines. And if you look on the right side of the scale and screen, we see that patients that are ACS patients, and they are now going to be treated with an oral anticoagulant plus aspirin plus clopidogrel in the cath. They come in, they can stop aspirin at 1 day or up to 6 months. So you can see that the guidelines are kind of like very vague about when you stop the aspirin. But I think what we're seeing now more and more, and I say this because you're going to get that from our cath lab and you're going to be wondering, what are we doing? We should be recommending directly from our cath report whether or not we want that patient to stay on aspirin, because they're going to need something for the atrial fib and they're going to need something for the stent, and they need a P2Y12 for the stent. There are some of us that will actually be bold and prescribe ticagrelor. Most of us are still prescribing clopidogrel. So here's the risk portion of our poster. I'll start from the top where it's the very high risk patients. Who are those very high risk patients? Those are the patients that present with hemodynamic instability. In other words, somebody has a fall in blood pressure, less than 90 millimeters mercury. And this is not due to sublingual nitro. It stays, it bottoms out and needs some resuscitation with fluids and pressors. This patient's a high risk. These are patients coming in with chest pain and presenting now with KILIP class 3, going into pulmonary edema, developed frank cardiogenic shock, class 4. Patients like the patient number 2 that I presented, who developed ventricular fibrillation, or patients with ongoing chest pain. You have somebody in your emergency department, more than 30 minutes of chest pain, and you look at them and they say, well, you know, they don't have any EKG changes, and you hang in there. That may not be the right thing to do, because what we're seeing is refractory chest pain. That patient may be infarcting all along and will need a different strategy. So if you look on the right side, it would be recommended that for those patients who are defined as very high risk, that they undergo urgent invasive angiography. And by that, the Europeans agree, the Americans agree, and we agree that they should be done on as fast as possible and likely within 2 hours. So I just want to point this out, that when you fill out the registry forms, that understand this kind of risk description. When we mean very high risk, we mean exactly these patients. High risk patients are those that have a moderate or high troponin rise greater than 5 nanogram per milliliter, and they have also EKG changes. And we recommend that these patients undergo invasive angiography within 24 to 48 hours. Now that's quite a mandate, because we know, you know, this is a target, but we know that there are patients in the periphery that we're trying to get over, and we're trying to make beds, and we're working hard to make beds, and we're not getting him here fast enough to make the 24 to 48 hour mark. And so we're trying to adjust to that, but this is an important target. Those that are medium risk, those are small troponin rise, some T-wave changes, patients with known coronary disease with EF of less than 40%, previous PCI, previous bypass, or people with renal insufficiency. These constitute a medium risk, and those patients can get an invasive angiogram at a later time. Some people would consider non-invasive assessment in some of these patients. In the very low risk patients with negative biomarkers, negative EKG, no recurrent symptoms, some of these patients could go home and be investigated non-invasively. So when we talk about is triage important? Triage is important at the Heart Institute. It's also important at your end. We know we are trying to do these, try to triage these patients as quickly as possible. So it's important that when I get back to why are we differentiating a primary ACS versus a secondary ACS, there's a reason for that. And the reason is that we want to be able to make room for those patients that are the true primary ACS, while the patients that have myocardial injury, the patients that have a little bit of rise in their biomarkers, patients like case 3 there with the pneumonia, where we feel that these patients should, the underlying precipitating factor should be treated first. Maybe we should wait a little bit longer on those patients in terms of referring for cath, in order that we can triage those higher risk patients that, as we described in our risk stratification. And let me tell you, you know, these lead aprons are often worn. I remember many years ago when we would see patients in a day unit, and at the end of the day, the labs would gradually shut down and our staff would go home. And unfortunately, we'd have to return patients back to the peripheral hospitals. These days, are not happening anymore. We stay here till we get the job done. I can't remember sending a patient back to a peripheral hospital which without having their angiogram done. So I think we work really hard here at trying to get the cases done. But I think that it's important that we let you know the whole team is staying here in order to be able to achieve this kind of goal. So we developed for those patients that are the very high risk, the one, the top of the box there, an algorithm that we call the code 4. We borrowed this code 4 name from the EMS, kind of stole it from them. Code 4 basically means lights and siren. It's a way of getting the patient over here fast. And in the past, we struggled with, the logistics, the clearing a bed and all that. But basically for these very high risk patients, we are committed to getting them here quickly. And I remember I talked about the hemodynamic instability, Culprit 3, Culprit 4, VFib, and ongoing chest pain. Some people would have liked that we included patients with ST elevation and AVR because people kind of feel, well, maybe that's associated with left main disease and we should include those on a, code 4 basis. And I think that, the Europeans would suggest that these patients undergo cardiac catheterization quickly. But after discussion, we felt that, we're going to get these cases done fast, but not as fast as the ones that we have on our code 4 list. Now, if that patient became unstable and became hypotensive, obviously we would be bringing over very quickly. So the management of primary versus secondary ACS, I want to come back over that again because I think it's an important concept that we get across. In the ACS, in the primary, the culprit is the coronary artery. In the secondary ACS, the coronary artery is a bystander. The ACS trials that we talked about, the Triton, the Plato trial, the Cure trial, all these trials, they were aimed at primary ACS, not the secondary. So the data that we've collected over the years doesn't necessarily apply to the secondary ACS patients. In the management of these patients, you treat the coronary if they're a primary. If they're a STEMI, you take them over, you open up the artery. If they're non-STEMI and they have a culprit lesion, you put a stent in it. You put them on antiplatelet therapy, and then you stage the lesion that hasn't been done. But these are the way of addressing the primary patients. The secondary, you treat the underlying problem. The case 3, you treat the pneumonia. And then you get the heart rate under control. You get the atrial fib under control. And then you reassess. And in this group, it's a mixed group. And if the patient suddenly starts having a recurrent chest pain, recurrent EKG changes, then it becomes maybe a different ballgame. Maybe that patient ruptured a plaque in the context of her pneumonia. So I think these patients are more complex in some ways, and they need more detailed assessment. In the situation with DAP for the primary versus the secondary, DAP applies to essentially most patients for primary, but maybe only to some patients with secondary. In terms of cathing people, we would cath most of our patients with primary, but it's not an automatic with the secondary. And what are the guidelines? They're directed mostly, the specific recommendations are directed at our primary, but they're more general recommendations at our secondary ACS patients. So the message that I'd like to leave with you today is that this understanding the concept of primary versus secondary MI, to try to apply the algorithm as faithfully as possible. Let us know how it works for you. Over the years, we'll still manage to change it if we have to. And use us as a resource. The triage staff and the residents are more than willing and able to help. So I'll pause there for a break in questions. Thank you for all this attention.
Thank you, Dr. LeMay. So if you'd like to ask your questions, I'll just ask you to raise your hand, and you can feel free to unmute when I call on your name. Yeah, and also feel free to use the chat as well. Okay, so Just seeing some comments here from our group. It's great. Thank you so much for the positive feedback about today's webinar. We really do appreciate it. Are there any particular questions about the STEMI protocol that we put out today for the webinar?
Sandra and Dr. LeMay, it's Erica here. I just want to commend you, Sandra, and Dr. LeMay and Jennifer Bradley for putting together this really informative presentation. I also wanted to just echo the comment, Dr. LeMay, you made about we have done a really great job at not sending patients back without having their procedures done. You know, in the past, that's always been a challenge and a heartbreaking thing to have to do when a bunch of STEMIs come in and patients don't get done and we have to send them back to the periphery. The staff staying now, getting everything done. So thank you for the continued hard work. I just wanted to also maybe put it out to the people on the call if there was any feedback for us as a group about that, or any questions related to that process either.
Yeah, so I see a hand. So Chris,
This is Chris.
Feel free to unmute.
I think Chris is still muted. Can you hear me still, Sandra?
Yeah.
Okay.
I can still hear.
I just put up a last slide there highlighting the collaborators, and as Erica said, a lot of people have worked on this project, and including yourself, Sandra, Jennifer Bradley, Marina Lepinas, Mike Froschel, and Chris Glover.
Yeah, I just see a comment from Tanya in our chat there. Can we access these algorithms on your website? The updated ones are not quite yet on the website, but we will share with you when they are. It should be very shortly, actually. So we'll certainly keep everyone updated, and you can get it from our UOHI website. And then I see a hand up for Dr. Graywall.
Yes, hi. Can you hear me?
Yes, we can hear you.
Okay, I just wanted to ask Dr. LeMay if we can just quickly go over the Afib and ACS patient again, because we work with our internists regularly about giving them advice at the time of admission. And so if we're giving them the Plavix and the aspirin, is it preferred that they remain on their DOAC throughout the peri-procedural period, or just wait from when their last dose was? In some cases, we might suggest, okay, don't give them anything, and then tomorrow start the enoxaparin if there's someone who's not going urgently, and maybe within 48 to 72 hours, and start it the next day, and then resume the DOAC when they come back from OHI.
So I think that atrial fib is a particularly complicated, more complex patient. And I think that you have to look at what is the risk of the patient coming in with atrial fib, and you're absolutely convinced that this is an acute coronary syndrome. It falls into one of the high risk categories, and you'll need an angiogram. I think if you're planning on doing an angiogram fairly early, I would prefer that, I think we would prefer that the oral anticoagulant be stopped. I think it's a little different than in the Bruce trial where they did ICDs and where they implanted pacemakers and they didn't stop warfarin. In this situation, doing a coronary angiogram on a patient who's already on an anticoagulant plus aspirin plus Plavix, and you do need the P2Y12 in order to prevent the stent from closing. So these studies have been done years ago. There was a STARS trial with Marty Leong that showed you need a P2Y12. So if you take away your Plavix or you take away the ticagrelor, you're increasing your chances of stent closure quite significantly. I think that we're trying to approach these patients more from the radial approach than the femoral approach. If you got a femoral, you know, problem in terms of like a retroperitoneal bleed, it'd be potentially fatal if they were all on all of these anticoagulants. You'd think that by doing by the radial, we can get away with it. But I think that you can still get some pretty serious complications in terms of bleeding in the arm. And, you know, how do you stop somebody from bleeding when they're already on a DOAC, when they're anticoagulated fully? And it makes it a little bit more confusing for us in the cath lab in terms of we got him on dual antiplatelet therapy, we got him on unfractionated heparin, we got a DOAC on board, and then suddenly they get a complication, and then we have to consult with maybe a vascular surgeon. I think that makes it really, really difficult. So if you feel that they fall in the risk of patients that are sort of high risk, then I would stop the DOAC. And I think that we should try to get them over quickly still, and like 24, 48 hours. And I think if they're super hot, then we'll do them on the DOAC. But if they're not, if they can be cooled down for 48 hours, we'd probably prefer that they be off of it.
Yeah,
and then if we have to start something like unfractionated heparin.
Yeah, I think that's a good point. Like, I think certainly our preference is to advise them to just hold the DOAC, but this is also a good case to just also remind them that unfractionated heparin should be the agent of choice, perhaps in that time period, because there will be a bit of crossover where they have DOAC in their system before it's restarted again. So that's helpful. Yes.
Okay. Some of the patients here, we are sending home on ticagrelor, and it's because it's in the context of a study. So far, most people feel a bit uncomfortable prescribing ticagrelor plus a DOAC or NOAC. And the reason is all of those studies that I listed there have been done mostly for all of them. They've been almost all done with clopidogrel. So there's very little knowledge on ticagrelor. And although they seem to say individually that they're not seeing any hint of stent thrombosis or ischemic events, and that they are all favoring less bleeding by using dual antithrombotic therapy, if you add them all up together and do a systematic review, there is a hint of stent thrombosis. So one of the studies we are doing at the Heart Institute is with ticagrelor in order to determine whether or not it is safe, because you may get more bleeding with ticagrelor, and maybe it is more of a pilot-like study, just to get an idea as to where we're going with ticagrelor in that context. So if you do see a patient with ticagrelor, it may be that patient is in a study.
Thank you, Dr. LeMay. I see, Chris, you have your hand up.
Yeah, sorry, there was a second mute button I didn't have on my phone to activate there. But Michel, and the whole team, again, congratulations for leading this and providing such awesome service for the region. And I think it's important to highlight how you did the secondary acute coronary syndrome patients, and that in some of these it's appropriate to pursue non-invasive testing. I guess my comment, just to think it over a little bit, is at the General and the Queensway and the Heart Institute, we have the luxury of consultants and lots of non-invasive scanners. However, for a lot of the smaller hospitals that refer, have none of that, and they have great service from our cath lab. But perhaps sometimes a non-invasive modality might be more appropriate. However, how does one go about getting that for these inpatients in a smaller center? How do you get a non-invasive test and a cardiology consult if that were appropriate? Is there interest in our sort of regional leadership for management of acute coronary syndromes to start to develop some pathways for that for secondary ACS? Have you thought about that? Can you comment?
Well, that's a great point there. I think that as we reach out to our community hospitals, I think that in building bridges, I think we have to understand what resources each of those hospitals has. And I think that this is maybe the next frontier in terms of where we could be going in terms of sharing and collaborating together. And I think that to know what are the resources and how we can help out our community to know to get these kind of non-invasive testing done in a timely way. I think Erica might be able to address that in terms of because we do have some of our physicians, and I know that Lyle, I believe, goes to Pembroke. We have some physicians that go out in our community, but there may be ways of expanding in a way that we can get some of our non-invasive testing done for these patients in a more efficient way. That's a good point. Thank you.
Hi, it's Erica. Just to add to that, that is great. And we are working right now, a group of us, with developing and rapid cardiac access clinic, and to provide rapid access both for imaging, for virtual assessments, and just access to cardiac consultations. So we're developing pathways and protocols. We're just started working on these before Christmas. So hopefully we will be reaching out, and we're actually, Sandra and I should be getting together soon to do an environmental scan of the needs of the communities as well. So thank you for raising this, because this is very timely. It is something that we do recognize, and it's good to hear that it's not just something that we thought of, that the community is also expressing this as a need. So thank you for raising that.
And if I might just add to that, Erica, it doesn't all have to be Ottawa Heart. I mean, we are certainly open, as we're hoping to do in heart failure, I would hope you would consider some sort of a spoke and hub model where, we've got the General, the Queensway, and other centers that have cardiologists and scanners, and we're definitely keen and happy to help out.
Absolutely. Thank you, Chris.
Thank you, everyone. There's just a few more questions here in our chat. So starting with DePhil, your question is, so in ACS while on DOAC, the ACS plus Plavix, but otherwise ticagrelor is preferred if not on DOAC.
That's correct, and we still see a lot of patients that come from the periphery, who are managed. They're the type 1 ACS patient. They're the classic patient. They're that case 1 patient who present and are treated with clopidogrel. And I think that the place where we should be using ticagrelor is in those patients who present with the classic type 1. I think that the Plato study showed that there was significant benefit. The CCS guidelines encourage us to use ticagrelor. We don't have prasugrel at this time. There's been sort of a comeback of that in Europe. So we can forget about prasugrel for now, but clearly if they are truly ACS, we would like to have them loaded up with ticagrelor. Now the issue becomes also if the patient is on a discharge on aspirin and ticagrelor, a number of them will develop some dyspnea. We see this in about 10% of the patients. And we get calls, and you have to you have to assess the patient and determine whether or not the dyspnea is actually ticagrelor. And in the case of ticagrelor, there should be no findings, like there should be no X-ray finding. There should be no evidence that this is heart failure. It should be just dyspnea, because there should be no actual physical finding when it's related to ticagrelor. And in a patient that cannot tolerate it, and there are times when they can't tolerate it, then you have to switch them over to clopidogrel. And then that becomes a responsibility, because you need to load them up. And the recommendation would be to load them up with 600 milligrams and to switch over the day afterwards on 75 milligrams of clopidogrel. And that can be, like if it happens on a bad weekend where the patient doesn't get his medication and 2 or 3 days go by without ticagrelor, and the patient's been just stented a couple of weeks into a stent procedure, that could be a problem. And we've seen that happen. So there has to be very clear instructions to the patient, especially now that we're in the COVID time, where we're doing everything by phone. I think their very clear messaging is very, very important when you make a switch from ticagrelor to clopidogrel.
Thanks, Dr. Lemay. We have 2 more questions. We'll just endeavor to answer them here. So we have a question from Maria. Thanks again for the talk. Can you please comment again on when you will accept for urgent cath when there is ST elevation in AVR? Must also have ST depression in minimal 6 leads or less.
Yeah, so those are the guidelines right out of the ESC 2020 guidelines. They actually say that they should be transferred quickly and done within 2 hours. This is ST elevation with 6 leads of ST depression, and often they have ST elevation in V1. And I think that does identify a patient at high risk. And I think if you give us a call, and I think that we are transferring these patients over. When we developed their code 4, there was some discussion about what is the magnitude of the risk. And some people felt that the original papers that were published on it exaggerated the risk of left main stenosis in that context. And the left main is the trigger. If they got left main, people are sort of very anxious. And so I think it kind of had a lot of weight in that paper, and it had a lot of weight in making the decisions to get these patients transferred very, very quickly. In fact, when we look at our STEMI database and we look at culprit vessels, it is rare to see a left main as a culprit vessel. That may not be necessarily the case with non-STEMIs, but in our STEMI database, it is rare because when you plug your left main, you go down very quickly. And many of those patients, we've had a couple of them that have made it to the Heart Institute, and they don't do well. They have really wide QRS when they plug the left main. So I think that in that study, I think there may have been a disproportionate number of patients with left main, and it kind of got people anxious about it. But I think we're still anxious about it. I think it indicates usually that they have concomitant, maybe severe bad triple vessel disease. There's something bad with seeing that. So I think if you call us up, most of us will feel like, let's get that patient over fast.
Great. So just last question from Nina. She comments, thanks for everything, Dr. LeMay and OHI. Question about enoxaparin dosing. QCH rounds dosing up to the next 10 milligrams based dosing to avoid multi-vial dosing of enox and reducing risk of medication error.
I'm not sure how much that culminates in smaller or larger dosage, but usually we recommend, I remember, is 1 milligram per kilogram up to 100 milligrams. I have to look back at the slides, but I'm not sure of any study that has looked at rounding. So that seems to be based more on an economic approach, and maybe the pharmacist would be better to comment on that. Where's the evidence for that?
Yeah, I actually didn't know they were doing that until a pharmacist reached out to me, Dr. LeMay, based after reading the new guidelines that were set forth, and so they reached out to me to ask how strongly that's proposed. To kind of be very exact with milligram per kilogram dosing. And they're more concerned about issues with errors with multi-vial dosing versus the exact weight-based dosing. So they reached out to me to ask you how important it is to have exact weight-based dosing. You're probably right. The evidence is probably not clear.
Yeah, my inclination would be to go on the basis of trials and what they've used in trials and try to replicate that rather than rounding to adjust for the vials. So I would be more in favor of looking at what evidence and what the doses were used in the different trials, like what was used in Essence and what was used in TIMI 11B, and try to use that if you're going to use enoxaparin. And the thing about enoxaparin is that, and that also goes for unfractionated heparin and fonoparadox, after being on those drugs for a number of days, and if the patient remains asymptomatic, and it looks like there's going to be a significant delay to go to the cath lab, they probably should be stopped at 72 hours. They are the drugs that we start the patients on, but they can also be stopped. And the reason for stopping them is that while they are on these drugs, they're also at risk of bleeding. And sometimes we've had some cases where they've had the renal insufficiency, it wasn't quite noted. And we've had a few cases where, especially like with enoxaparin, where it can accumulate. You can get major bleeding with that if you don't pay attention to the renal function. So after 3 days, the patient's asymptomatic and is still planned to, go to the cath lab. And then when there's delays, I think I would stop the drug, either unfractionated heparin, fonoparadox, or enoxaparin.
Okay, thank you. I'll just touch base with the pharmacist to see to assess their degree of concern about medication error and tell them. Thank you.
Yeah.
Well, thank you everyone for attending our ACS webinar this evening. We really appreciate your your engagement and also ongoing collaboration clinically to take care of our ACS patient in the region. So thank you so much. I've just put our contact information on the chat there. If you have other questions following our webinar, please feel free to reach out to myself or Jen Bradley. And also Dr. LeMay will certainly, he'll be happy to answer your questions as well. Thank you again, and hope you have a wonderful evening. Take care.